Good afternoon. Today we're going to present the limitations of current research of performance-based outcome measures in adaptive athletics.
I'm Sage.
I'm Allie.
I'm Charlotte.
I'm Nicole.
And I'm Celine.
The scope of this research focuses on the conditions of cerebral palsy and spinal cord injury for ambulatory and non-ambulatory athletes. The adaptive sports population we are interested in include adaptive sprinting and wheelchair tennis. Cerebral palsy is a neurodevelopmental disorder of the brain manifesting in utero or early childhood. These impairments present as muscle contracture, spasticity, discoordination, and muscle weakness that affect range of motion, motor control, and balance. The overall prevalence of CP is estimated to be about 2 per 1,000 live births. While CP is congenital and involves the brain, a spinal cord injury is primarily the result of a traumatic injury to the spinal cord with associated motor and sensory deficits below the level of the injury, often resulting in paraplegia. Prevalence is estimated to be about 906 per million in the United States.
Adaptive sports provide the opportunity for people with disabilities to participate in sports at a recreational and competitive level. These sports follow the same structure as able-bodied forms with some minor accommodations for different levels of impairment. For example, athletes who participate in adapted sprinting use modified starting blocks or choose to forgo them entirely. Athletes with more severe conditions can use a specialized track chair, as shown in the picture, to compete. Also, athletes who participate in wheelchair tennis are allowed 2 bounces to get to the ball versus 1.
Studies by Leip and Tweedy have shown that participation in adaptive athletics has both physical and mental benefits by improving overall health and transforming athletes' self-image. Solin and Lexel further reported on the impact of organized sports within the population of neurological disabilities, including CP and spinal cord injury, and found that individuals demonstrated greater life satisfaction and reduced incidences of psychological comorbidities. Given that adaptive athletes are higher functioning than the general population, athletes often are limited by a ceiling effect. The ceiling effect occurs when subjects score in the maximal range during baseline, resulting in a decreased capacity to detect improvements in score throughout subsequent testing. The purpose of our literature review is to determine what assessment tools can be used to track the progress of competitive adapted athletes. Current literature highlights outcome measures that include multiple performance-based skills that contribute to balance, stability, coordination, power, and speed in able-bodied athletes, but there's limited research on the adapted population.
For the sake of our research, we decided to divide the athletes into ambulatory and non-ambulatory. So first, we're going to talk about the outcome measures that apply to our ambulatory athletes. These will include our sprinters with CP.
The Illinois Agility Test measures an athlete's agility, or the ability to move quickly and easily. The athlete begins at the starting point in prone, sprints to a cone 30 feet away, turns, sprints back to the start point, swerves in and out of 4 cones, and completes 2 more 30-foot sprints to the finish point. The IAT is reliable and valid. It's easy to administer with minimal equipment and low cost, and takes speed into account, which is important for our sprinters. It also has a high correlation to the CHAMP test, but takes much less time to administer. Unfortunately, the studies that assessed the IAT did not match our population exactly, since they used service members who had lower limb loss, resulting in use of a prosthetic. While our population is not well represented, this has been proven as a reliable and valid measure for assessing high-level ambulatory athletes. Further, the agility component that this measure assesses is less important to sprinting. However, we are hoping to turn the focus of our research towards interventions that will improve overall performance. So this is an appropriate measure to assess the ability to move in all planes of motion, which we intend to work on with our athletes.
The Comprehensive High-Level Activity Mobility Predictor, or CHAMP, was another outcome considered for ambulatory athletes. The CHAMP comprises 3 tests: the Edgren Sidestep Test, the T-Test, and the Illinois Agility Test, all of which assess mobility throughout different planes of motion and require different components of speed, coordination, and agility. For the Edgren Sidestep Test, individuals sidestep across 4 meters as quickly as possible and return in the same manner to the starting position. For the T-Test, individuals are timed as they navigate the T-formatted grid, as shown in the bottom right photo. An Illinois Agility Test was previously explained by Charlotte. Individuals are given a composite score with a higher score indicating greater mobility. the CHAMP has been shown to be a reliable and valid measure in assessing male service members with lower limb loss. And the CHAMP was developed to specifically assess high-functioning individuals with disability in order to eradicate the ceiling effect of other common mobility measures. However, given the population was done on male service members, the results lack generalizability to our female collegiate level athletes.
So this is the muscle power sprint test. The MPST is a test that's comprised of 6 15-meter sprints with 10 seconds between each sprint. Each sprint is timed by the assessor, and the power is determined by the equation here on the bottom right. ICC values for test, retest, and inter-rater reliability were excellent, and construct validity was excellent in being able to show a difference between CP classifications. The test has excellent criterion validity because it is highly correlated with the gold standard for assessing anaerobic power. So this would be the Wingate anaerobic cycling test. The MPST is going to be more useful than the gold standard for our athletes because they're sprinters and not cyclists. So being able to test them and analyze power while they're sprinting is very important. So it makes this test sport specific, especially for short distance sprinters. This test is also feasible and it doesn't take too much time to complete or set up. And it doesn't require extensive materials. You can see here they only use 4 sets of cones. A disadvantage is that the test only requires athletes to work in the sagittal plane, so we don't directly see improvements in other planes of motion if we plan to use interventions down the line to target impairments in other planes. Another disadvantage is that studies which found the psychometric properties of this test used children with spastic cerebral palsy as their subjects. And as we know, collegiate athletes at SDSU are going to fall outside of this age range. And so it's questionable as to if these excellent reliability and validity values are going to be generalizable to the collegiate athletes that we'll be working with. So further research needs to be conducted here with the adult population that has cerebral palsy.
3 horizontal jump tests of forward bounds can be measured using a metric tape on the floor and showed excellent intra-session reliability in soccer players and CP athletes. These 3 tests include the standing broad jump, 4 bounds for distance, and triple hop for distance on the dominant leg and the non-dominant leg. The standing broad jump starts with the legs close together and a bilateral takeoff and a bilateral landing. The 4 bounds test involves the subject to perform a series of 4 forward bounds with alternate right and left foot contacts, beginning with the non-dominant leg. The triple hop for distance on the dominant and non-dominant legs tests involve 3 consecutive maximal hops while landing on the same leg, dominant and non-dominant. Each test records the total distance in meters. The test demonstrated that the intra-session reliability in soccer players with CP was excellent and good in the control group without CP. Forward bounding is essential in soccer and track and can help assess strength, power, and acceleration capacity and coordination, which may be impaired in cerebral palsy athletes. Another advantage of the horizontal jump test is that the clinician can assess dominant versus non-dominant leg. Athletes with cerebral palsy often are more limited on one side than the other, and this difference can be used to influence training to become more symmetrical. The first disadvantage of the test is that it has not been tested in track athletes with CP, only in soccer players. The study assessed criterion validity comparing the subject's horizontal test to a vertical jump test for a counter movement jump on a force plate. The relationships were significantly correlated but may not assess the same components of strength, power, and coordination, and acceleration and deceleration. Lastly, the inter and intra-rater reliability were not tested, so it's difficult to know if they are truly reliable. Although we would prefer if there was data on our specific population, track athletes, the horizontal jump tests are feasible and reliable and may provide adequate objective measures to track performance throughout a season with training and therapeutic interventions.
The next few tests that I'm going to talk about are ones that we analyzed but decided not to use. I will keep it brief with these tests since they are commonly used and most of us should be familiar with them. So first I'm going to talk about the timed up and go test, or the TUG. The picture on the bottom can be used as a reference to see how the test is completed. When looking at this test, we noticed that it was deemed reliable and valid, but only for patients with Parkinson's. Although it involves a power component when the individual is asked to quickly push up from the chair, it is not specific enough for sprinting. Other common benefits for many of these tests are included as well. However, the ceiling effect is expected since the test is not intended for higher level athletes and is typically used for the geriatric population. Even though it may appear that the test should be used based on the advantages, the disadvantages far outweigh the perceived benefits. The 6-minute walk test was considered for its reliability and validity for ambulatory people with spinal cord injuries. However, this does not include our athletes with CP. The same advantages and disadvantages are seen for this test, with the only main difference being that there is no power component in this test. Since participants are instructed not to run, the lack of specificity for sprinting deems it not useful for our study. The next few tests are very similar as far as advantages and disadvantages go when being considered to assess our athletes. The 5-time sit-to-stand test was deemed reliable and valid, but in children with CP. We are unable to use an outcome measure that has only been proven reliable and valid on children because the age range is outside of our population of interest, and obviously their activity level would be different. The test includes the power component of the tug, but still produces the ceiling effect and is not sport specific.
The 10-meter walk test is another functional assessment utilized for children with CP. Participants are timed as they walk a straight line for 10 meters at an individualized normal walking speed. Previous studies indicate high retest reliability, as well as high validity when compared to the gross motor function measure, a previously established measure. Despite the fact that 10-meter walk evolved as a feasible, reliable, and valid measure in determining walking functional ability for children with CP, given the high mobility status of adapted athletes, this measure would be prone to ceiling effects. Furthermore, the 10-meter walk test is not as demanding as the 1-meter walk test, considering it's done at a self-selected walking speed. Therefore, the 1-minute walk test is considered to be a better assessment of functional ability with respect to endurance, strength, and functional balance for this population.
Lastly, for our ambulatory athletes, we had discovered the 1-minute walk test. This test is not as common, but is similar to the 6-minute walk test, just a shorter duration. It is originally intended to assess fall risk for children with CP. Despite it being deemed reliable and valid, it does not match our athletes' demographics. Other common benefits and limitations are seen again with this test as well. It is also noted that there are no validity statistics given, and the test cannot be applied again to our higher level athletes. So now moving on to non-ambulatory athletes, we analyzed 3 different outcome measures to potentially assess them.
The IAT, as discussed earlier for ambulatory athletes, can be modified for athletes who are in a wheelchair. These athletes compete the same agility course, but begin with their caster wheels behind the starting point. The modified IAT is reliable and valid, easy to administer with minimal equipment and low cost, and is specific to assess movement and performance in our sport of interest, wheelchair tennis. A main disadvantage of this measure is how limited the research is, since it was difficult to find articles that use this measure to assess our population of interest. However, the articles that did utilize this measure deemed it reliable and valid to assess performance in different levels of athletes who play wheelchair tennis.
The modified functional reach test has been adapted from the functional reach test to assess balance in individuals who cannot stand, including individuals with spinal cord injury. In this reaching task, individuals are seated against a backboard, their shoulder flexed to 90 with their arm extended, as seen in the photo, and asked to reach as far forward as possible without stabilization of the opposite upper extremity or the lower extremity. And raters must remember to keep an eye out for this compensation, as balance is an important component to our sports performance, especially in a population with balance compromised. This test was considered. However, although it's been shown to be reliable, validity has not been established.
Okay, so another test that we found is the wheelchair mobility performance test. This is a complex test that is comprised of 15 different skills commonly performed in wheelchair basketball matches. For example, some tasks include in a 180-degree rotation to the left and then to the right, a 12-meter dribble, or a 12-meter rotational dribble. The score is the overall time to complete each task. The test has excellent reliability values and excellent construct validity. But the construct validity is also on the disadvantages list because although it was able to differentiate between sex and playing standard, the test was not able to show a statistically significant difference between low and high classification athletes. You see the p-value is 0.06, which is right on the cusp. Other disadvantages are that the tasks which involve turning and rotation and pivoting have poor reliability and poor construct validity, but they're still included in the test. Time may not be a reliable outcome measure for these quick functional tasks. The test is, like I said, very complex, and the time that it takes to explain the test and each of the 15 activities and measure the performance induces a burden on the rater and also a burden on the athlete who's performing the test. The test is also going to be more challenging for athletes who may have intellectual comorbidities, so it's not going to be suitable for all athletes. Now, this is a wheelchair basketball test, so it's not a good test to assess SDSU's wheelchair tennis players, mostly because many of the skills are completely different. We included this test because of the excellent psychometric properties, and overall the idea behind this test is really good, and it should be used as a template for creating a very specific mobility performance test for wheelchair tennis athletes.
Despite the wide variety of outcome measures we have discussed, there is a lack of sport-specific measures with good to excellent psychometric properties. There is also a lack of studies testing performance measures for the adapted athlete population. So there is clearly a need to advance research for adapted athletes, so programs like the Paralympics and adapted athletics can further train athletes to maximize performance.
For this project, the focus of our research was to examine the literature for sport-specific outcome measures that we might use to track progress in adaptive athletes at San Diego State University, specifically high-level collegiate track athletes with cerebral palsy and wheelchair tennis athletes with spinal cord injury. And after reviewing the evidence and comparing the benefits and disadvantages in this presentation, we concluded that the horizontal jump tests and the Illinois agility tests are the best outcome measures to use for the track and field athletes. And the modified Illinois agility test will be the most useful test available for wheelchair tennis athletes. These tests have the best psychometric properties. Like Ali mentioned, the jump test is really valuable because we get a clinical picture of the lower extremity unilaterally and bilaterally. The Illinois agility test is useful because it tests the athlete's speed and agility while looking at multiple planes. And overall, we found very limited outcome measures for high-functioning wheelchair athletes. And so when we compared to the last 3 outcome measures, we found that the modified Illinois agility test is going to be the most sport-specific for the wheelchair tennis athletes.
Thank you.
Thank you.